Okay, hello everyone. I'm Dr. Nawal Nazam. I'm going to give a brief introduction of mine. I've been taking classes since 2 or 3 months. Many participants have volunteered. Today, our volunteer is Dr. Atka Nisar, and the task is, let me read the task. This is a
Yes, madam.
31-year-old female who has presented after miscarriage with irregular vaginal bleeding. How will you proceed, Dr. Atka?
Okay.
This is a structured discussion.
Okay. Assalamu alaikum. My name is Dr. Atka. I'm one of the exam candidates, and I've read the structures, and I'm ready for the structured discussion.
Okay.
First of all, I will start with the history.
Mhm.
In history, I will ask about the biodata of that female, including name, age, parity, married for, and uh, then I will proceed towards the. Hello.
Yes, I'm listening. Continue.
Okay. Okay. Then I will proceed towards her presenting complaint. That is, she is bleeding since 3 weeks after miscarriage. I will ask about her pattern of bleeding. Is it continuous since 3 weeks or it is intermittent? How much is this in amount? Is it associated with clots? How much pad she is using per day? Is it how much affecting her quality of life? Then how much what is it associated with any pain? If pain is present, then it's site onset, severity, duration, aggravating relieving factor. And then I will ask about her miscarriage history, like either this miscarriage was induced or spontaneous, followed by any evacuation, and any product of conception were sent for histopathology, and any history of instrumentation in this miscarriage. Then I will ask about.
Okay, 1 second. So she has
Okay.
underwent miscarriage at a clinic of Vadai. She was living in a village, and now she has come to you.
Okay. They induce in private village.
You are a doctor at a tertiary setup.
And I will ask whether she I told her about the any product of conception, what kind of they were.
No,
And because
she did not tell her anything. She has just a paper that she underwent miscarriage and evacuation was
okay,
done by a dai at a private clinic. How will you proceed now?
I will ask about that pregnancy, that has she done any ultrasound in that pregnancy, how much was duration this before miscarriage, how much was the duration of the pregnancy, and any ultrasound was done in that.
Pregnancy was of 6 to 7 weeks.
Okay. Any associated discharge or lower abdominal pain since then?
There is mild intermittent pain. There is no discharge.
Okay. And were her previous cycle was normal before this pregnancy? Any intermenstrual postcoital bleeding?
Yes.
Normal. Any fever or any fever since the bleeding is present? Any sign of infections?
No.
Okay. And then I will ask generally about any past medical, surgical, and drug history or socioeconomical, like any addiction.
Okay. Everything else is normal.
Okay, then I will proceed towards the examination.
Okay.
To look
What are you going to ask in physical examination?
on general physical examination, I will look for the general look and pallor.
And what else?
And on vitals, vitally stable, pulse, blood pressure.
She's vitally stable.
Okay, and then on local examination, I would like to see on per vaginal examination any bleeding and
Yes,
discharge present at that time.
there is bleeding now present.
Any local pathology,
No, there is no local pathology. Anything else you want?
uterine size, adnexa.
Uterine size is 16 weeks.
Okay. And adnexal fullness, any mass.
There is no adnexal fullness.
And okay, then I will proceed towards the investigations.
Okay, what investigations you want?
Any if herself is done UPT or beta HCG after baseline investigations.
Okay, UPT is positive.
Baseline.
Yes, UPT is positive. What else?
Beta HCG you've done.
Beta HCG, yes, beta HCG quantitative is available. Its value is up to 30,000.
Okay. And baseline investigation CBC.
CBC hemoglobin is 9.
And urine complete. Any significant
Urine
finding.
complete is normal. What else you want?
And then I will proceed towards the ultrasound findings.
Okay. TVS is showing bilateral theca lutein cyst, and there is a 5 centimeter mass inside. There is a 5 centimeter mass in the uterus. Heterogeneous mass.
And any other investigation if done?
No. These are the investigations available. How will you manage this case now? What are your differential diagnosis and what is your provisional diagnosis?
My provisional diagnosis is molar pregnancy.
What are your differentials in this case?
Differential are
based
ectopic
on
pregnancy.
Based on history.
Based on history is gestational trophoblastic disease.
What else?
And subinvolution of uterus. And invasive mole.
Okay. How will you manage this case?
I will start with the counseling of the patient, explain the diagnosis that she is having this condition and the effect associated with this, certain risk factor associated that are bleeding and bleeding associated with the.
Okay, let me make it easy for you. How will you score this? Okay, this is a case of molar pregnancy. How will you molar pregnancy / choriocarcinoma? Okay, the diagnosis is choriocarcinoma. How will you score the disease? What is your scoring?
Scoring will be done according to the FIGO criteria.
Okay.
If the score is up to 6, then
what
it
is
is
your score in this case? This patient is 31 years of age. She has miscarriage. Her beta HCG is 30,000. What is your score in this case?
Ma'am, what is parity?
Parity, she is gravida 3, para 0 plus 2. Two miscarriages before.
Okay. The score according to this, let me calculate it. 30,000. Or history. after miscarriage is 0, 2 plus 2 and
Okay,
zero.
let me
4.
make it clear for you. This score is less than 6. Okay.
Less than 6. Yes.
Yes. How will you stage the disease?
Ma'am, staging.
Do you remember the stage?
Staging there, ma'am, 4 stages, 1, 2, 3, 4.
So in this case, I've told you the mass is present in the uterus, 5 centimeter heterogeneous mass. So this is stage 1 disease.
Okay, this is stage 1
Okay.
disease.
So how will you manage this case?
Ma'am, management will be done according to the management. After the counseling of the patient, I will involve the multidisciplinary team. Patient will be evaluated from the oncology and anesthesia and psychological counseling of the patient will be done. And then management is there are two management will be done by, first of all, will take the anesthesia fitness of the patient. If she is a fit, like HB is optimized, if there HB will be optimized, if there is any risk factor will be ruled out, and then we will proceed towards the chemotherapy of that patient. As the patient is having score of less than 6, we will start with the methotrexate therapy.
Do you remember the dosage
injection.
of the methotrexate?
Methotrexate is given as 50 milligram per kg of the patient body weight, and
On which
it is alternatively
Can you tell
given
me
with
the
the
date?
folinic acid. At day 1 we give
Day 1357. Okay.
day 1 we give injection methotrexate, and yes, and day 2 give folinic acid, and this cycle is continued.
Okay. How will you? Okay. So what surgery are you planning on this patient?
No, ma'am, surgery is not done, as she's already has evacuation done.
So you are planning for
It
chemotherapy
will be
and not for surgery.
Surgery will be done after the discussion with the multidisciplinary team.
Okay.
That if the mass has to be removed again.
Okay. How will you follow up this patient?
Follow-up will be the it will be according to the we will give chemo, and we will see if the beta HCG has fallen to the normal level. We
For how many
do
weeks
the beta HCG level.
For how many weeks you are going to follow the patient?
We follow the patient for
okay.
First of all, we follow the patient weekly, and then we will follow up
For
after
how many
chemotherapy is weekly is
okay.
for 1 year. I just remember.
It's
Sorry, I
for
forgot. I just remember
Dr.
1 year
Atka.
follow up after chemotherapy.
Okay, Dr. Atka, it's weekly for 3 weeks until the beta HCG normalizes. Okay, and then it's monthly. Then it's monthly for 12 months.
Okay, 3 weeks weekly and then monthly for 12 months.
Until the beta HCG normalizes.
Okay.
Okay. So let me see your timer if you have finished the case in time. Yes. So it's 10 minutes. Okay. We said that we are going to do a long case, but it will become a short case because of 56 days. Yes, that is another type of follow-up. I am telling the follow-up according to the FIGO regimen. We do the follow-up. Yes, Dr. Shiri is saying right. The 56 days, that is for 8 weeks, that is written in green top guideline. I am telling you follow-up according to the FIGO regimen, that basically we do the follow-up for 8 weeks till the beta HCG normalizes, or after chemotherapy it is for monthly till 12 months. If the tumor is not metastatic, But if the tumor is metastatic, it is monthly for at least 24 months. Yes. 56 days is for gestational trophoblastic disease. I'm talking about choriocarcinoma. So basically, this case was a choriocarcinoma. I am going to tell you about the differentials and what were the differentials in our mind, in my mind, and what were the things that you missed in this case. Okay. So the differential diagnosis is that number one, it could be retained product of conception again. It could be molar pregnancy, it could be heterotopic pregnancy or pregnancy of unknown location. It could be genital tract pathology, it could be any because of any contraception she's taking. Yes, you missed the history of contraception, Dr. Atka.
Yes, contraception I didn't have.
Yes. Then you asked about the foul smelling discharge. So you could have been thinking about puerperal sepsis after miscarriage because it was a dye-treated case.
Yes.
Yes, you have missed the history of pap smear. It could have been cervical cancer.
Yes, pap smear contraception.
Okay, so in history, your history was good, and you have almost taken all of the history. I think the thing that you have missed, which was important thing in this case, was the blood group of the patient.
Yes, because entities had to be given.
Yes. A blood group was important. Then I think the scoring system should be on your fingertips.
Yes, madam.
Yes. Staging should be on your fingertips. If the score was less than 6, because age is 31, so the score is 0. For abortion, score is 1. And for 30,000, the score is 1. So, and there were no tumor. There were only the size. For size, it was 5 centimeter. So for 5 centimeter, the size becomes 2. So it was almost 4 to 5 score. It was less than 6. That's why we opt for single agent chemotherapy, that is methotrexate. We give methotrexate as 8-day regimen, 50 milligram per meter square intramuscularly on day 1, 3, 5, 7, with folinic acid, which is 15 milligram orally 24 hours. And we repeat it every 2 weeks. I am telling this according to FIGO regimen, according to FIGO update of 2021. Okay. Then follow-up is according to the Green Top guideline, it is for 56 days. But according to FIGO, they say that until the beta HCG normalizes, and then after chemotherapy, it is monthly for 12 months. For 12 months for non-metastatic tumors, and for metastatic tumors, it is monthly for 24 months. Any feedback or questions you want to give, or any? I will give you at least 6 marks, Dr. Atka. You are passed in this.
Thank you. लेकिन मैम ये याद करना है ये जो
yes figure. Yes. How will you how many marks you will give yourself?
4 or 5.
4 or 5. I think it was a good attempt on your part, but in this case you have to cram some dosages and you have to cram the scoring and the staging. Anyone else wants to ask any question?
मैडम आपने फीको का क्या फॉलो अप बताया कि जब तक बीटा एचसीजी नॉर्मल नहीं होता तब तक कितना है?
वीकली करना है.
वीकली. और मैडम सीरम में या यूरिन में?
सीरम में, यूरिन में, किसी में भी कर सकते हैं, बट आई थिंक सीरम में इज बेस्ट बिकॉज बीटा एचसीजी क्वांटिटेटिव लेवल्स हमने फॉलो करने हैं ना, तो सीरम में ही करेंगे. Anyone else want any question?
अस्सलाम वालेकुम डॉक्टर.
जी डॉक्टर शीरी.
जी जी. अच्छा, ये पार्शियल मोल अगर है तो इसके फॉलो अप के कितने वक्त के बाद फिर हम इसको अलाउ करेंगे प्रेगनेंसी के लिए?
पार्शियल मोल है, आई थिंक ये जो मैंने बताया आपको, ये फीगो रेजिमेन बताइए फॉर कोरियोकार्सिनोमा. पार्शियल और कंप्लीट मोल के लिए द फॉलो अप इज सेम एज रिटन इन ग्रीन टॉप गाइडलाइन, जो 56 डेज वाला है, 8 वीक्स वाला है.
वो तो ठीक है, नॉर्मल हो गया 56 डेज पे, लेकिन अगर वो पार्शियल मोल है तो फिर उसको कितने वक्त के बाद करेंगे?
पार्शियल और कंप्लीट मोल को वैसे ही फॉलो अप करेंगे। ये जो मैंने फॉलो बताया, दिस वाज फॉर कोरियोकार्सिनोमा। ओके, कैन एनीवन टेल व्हाट इज द डिफरेंस बिटवीन कोरियोकार्सिनोमा एंड इन्वेसिव मोल?
इन्वेसिव मोल में प्रोफ्यूज ब्लीडिंग होती है और विद इन 12 मंथ्स के अंदर अंदर अगर हो।
नहीं, ये डिफरेंस नहीं है, कोई और बताए। कोई और बता सकता है डिफरेंस बिटवीन कोरियोकार्सिनोमा एंड इन्वेसिव मोल? अदरवाइज आई विल टेल द डिफरेंस।
मैडम, इन्वेसिव मोल जो होता है वो उसका ऑनसेट जो होता है वो ग्रेजुअली होता है, यानी कि कोरियोकार्सिनोमा की सडन क्विकली अपीयर होता है, और
इन्वेसिव
इट इज
मोल,
लेस aggressive होता है as compared to invasive mole. Invasive mole is more aggressive and it takes longer time
the
to show.
most important, the significant difference between invasive mole and choriocarcinoma is that choriocarcinoma, it is a histopathological diagnosis, and there is absence of chorionic villi in choriocarcinoma, but there is presence of chorionic villi in invasive mole. So both of these are histopathological. They say that choriocarcinoma is a clinical diagnosis, but on histopathological diagnosis, if there is absence of chorionic villi, then this is choriocarcinoma, like in this case. But if there is chorionic villi are present, then it's invasive. Okay. Feedback and questions are welcome. If there is any other question, you can ask me, or otherwise I'm going to end the session. Any other question? You can post feedback in the group. Okay, thank you so much, everyone. You can subscribe to my channel and you can ask me any question. Thank you. Thank you, Dr. Atka, for being a volunteer. Okay.
Thank you. Thank you.